Okay, good evening, everyone. Assalamu alaikum. So the screen is audible to you? Screen is visible and audible? Okay. Screen is ঠিক আছে? স্ক্রিন ঠিক আছে সবার? ছোট নাকি বড় একটু জানান। স্ক্রিন কি ঠিক আছে? ছোট করব না বড় করব? Okay.
Okay, ma'am.
Okay. Yes. Any question before we start these guidelines? So this guideline has how many pages? Who can tell me how many pages this guideline?
407.
407. 407. Okay. So can we read 407 pages? No, we cannot read 407 pages. Okay. So we have to know that in which chapter we have to give importance. We have to give stress in which chapter, right? And this is a big guideline. Neonatal, you know, the neonatal medicine is a branch of pediatrics, but it's at the same time neonatal medicine is very, very vast. Okay, so we cannot complete this in part 1. Also, this guideline will be needed for part 2. In AKP also we will read this guideline. So better now we concentrate for part 1 because this is our part 1 class today. So what we will do, we will discuss every chapter that is important for our part 1, not for AKP and not for like clinical, okay? Because there are some chapters you will read in AKP more, and there are some chapters you will read in clinical more. Got my point? So this book is not only important for part 1, also for AKP and clinical, like pediatric guideline red book. Some people has confusion that is this the NICE guideline? Actually, NICE is a collaboration of a group of organization that is called trusts in UK. So these guidelines like Red Book and Neonatal Blue Book, these guidelines are published from those trusts, local trust, and they collaborate with the NICE guidelines. So this is not a difference. There is no difference between the NICE guideline and the Red Book and the Blue Book. Okay, there is no difference or very negligible amount of difference. Clear? So you can read these two books, Neonatal Blue Book and the Red Book Pediatric Guideline. And in our class, what we will do, I have part 1 batch and I have part 2 batch, as you all know. A different batch, I have different preparation. So today is a part 1 batch, and I will highlight the question that will come in part 1 mainly, but it will be helpful for AKP student also. That's why I invited them to join today, because in AKP also similar guideline, but the question pattern will be changed. In AKP you will get a lot of difficult question that will be a big question. Okay, so let us start today now this Neonatal Blue Book. Before I start, anyone has any question about anything, any topic you can discuss? Any question about this Blue Book? Okay, so you can see there are 407 pages in this book, and see this chapter, and the page number is not serial. Can you see this? These page numbers are not in serial. They are like, they are divided into chapter wise. So you have to see first, before starting this book, you have to see what are the chapters you have in this book. And suppose from the admission and discharge, which chapter we will read? Okay, criteria for neonatal admission, suppose. So what are the babies that will be admitted in neonatal ICU? So this is an important chapter. From the cardiovascular murmur chapter and supraventricular tachycardia chapter, and there is pulse oximeter. Another chapter is pulse oximeter. We will read that one. Okay, so like from which chapter, which question will come in exam? This is a basic understanding. Okay, because when you are preparing for any exam, you have to know the syllabus, you have to know the limit, because we know knowledge has no limit. Okay, even if you want to read this full book, you can read. Okay, hello. Is it audible to you now?
Yes, ma'am.
So you can read this full book, but for exam you have to know that which chapters are very important. Okay, so let us not waste our time. We start our chapters. So according to our group, which chapters is first? 340 page, right? What is the name of the chapter? 340, page number 340. What is the name of the chapter?
Ma'am,
Supraventricular.
supraventricular tachycardia.
Okay, so let us start. I made this list for you so that you can understand that which chapter is a must to read and which chapter is a nice to read. Okay, see in the page that I gave you, some chapters I wrote reading, and some chapters I wrote must. Okay, so from the must to read chapters, we will highlight the question that will come in our exam in Mrcpch part 1, and also some question from AKP. Okay, let us discuss. So from supraventricular tachycardia, anyone can tell me, is there any difference in presentation of supraventricular tachycardia in neonate and in children? Can anyone tell me that is there any difference? How you know that neonate presented with supraventricular tachycardia? Neonate cannot speak to us that I have tachycardia. Like in older children, what will be the presentation? In older children, the child will be saying to you that I feel my heart is racing, my heartbeat is racing, I feel very dizzy. Okay, or he will have fainting attack. Okay, but in neonate, they cannot tell you that I have feeling dizziness or I am feeling fainting like this. So in neonate, remember the presentation of supraventricular tachycardia will be shuttle, just like neonatal seizure. Sometimes neonatal seizure is very shuttle. So what will be the sign and symptom? You have to know. Okay, very few point. In every kind of supraventricular tachycardia, we know that heart rate will be more than 200. Okay, and tachycardia, it is supraventricular. That means it arises from above the ventricle, not at the level of ventricle, because if it is at the level of ventricle, then what we call it, it will be called as ventricular tachycardia, and that is a very serious condition. But supraventricular tachycardia, if you manage early, this is life saving. Okay, this will be life saving treatment. So let us read. The supraventricular tachycardia can be, we know, AV, atrioventricular nodal re-entry. This is called AVNRT. Another is atrioventricular re-entrant. This is the most common, AVRT, re-entrant. Okay, and this supraventricular tachycardia can be presented with congenital heart disease. Okay, so remember this supraventricular tachycardia, if any neonate presented, then you should do what? You should rule out congenital heart disease like Epstein anomaly, okay, ASD, they can be associated. So you have to do an echo. Okay, this question I think came in exam, that what investigation we do for supraventricular tachycardia. Okay, if it is presented in early life, definitely we will do an echo. So now symptom and sign, as I said, supraventricular tachycardia sign symptom will be like shuttle sign symptom, like they will present in delayed relaxation of feeding, poor feeding, sweating, breathlessness, signs of heart failure, tachycardia, tachypnea. Mother cannot say tachycardia, tachypnea. Mother will say, my baby is not having breast milk. He is sweating. He is having, I feel that he has some respiratory difficulty, breathing difficulty. This will mother say. And what you will examine, when you will examine, you will check heart rate is very high. So then and then what you should do? You should put a chest lead, ECG. And also you should put 4-limb saturation, because the baby may go into heart failure and also saturation will be low. So any neonate who presented with tachycardia, you should put chest lead, and also you should check 4-limb blood pressure, forelimb saturation, for coarctation, right? So many baby actually tolerate this SVT. But if SVT is more than 6 hours, there will be sign symptom of heart failure. So it is not a very dangerous condition if you treat early. But if you cannot treat, cannot pick up the condition, it will be very dangerous and life-threatening condition. Now, what are the causes? As I told, this is unknown. Cause is unknown, but sometimes it is associated with congenital heart disease. And suppose that is TGA, Epstein. Okay. And another point we discussed that any baby who has suppose congenital heart disease, but the baby is having respiratory tract infection, if the baby has respiratory tract infection, or suppose the baby is less feeding, they can trigger this supraventricular tachycardia in case of dehydration or less feeding or infection, pneumonia. Okay. Now, heart rate will be more than 200. As we said, heart rate will be more than 200, and there will be capillary refill time will be prolonged. If you measure the blood pressure will be low. Okay. And you have to examine the cardiovascular and respiratory system detail. Okay. Investigation, as I said, 12 lead ECG. Of course, septic screening. Remember, any neonate presented with you with failure, breastfeeding failure, lactation failure, or with lethargy, tachycardia, tachypnea, think about sepsis always. Okay. And some question will be, what is the immediate investigation for management purpose? Always remember, tachycardia, tachypnea, immediate investigation is blood gas. Okay, mark it down. Any neonate who will presented with tachycardia, tachypnea, features of sepsis, immediate investigation will be blood gas. But you have to rule out sepsis first. You have to put the ECG lead. You have to do forelimb saturation and forelimb blood pressure to rule out the coarctation and other varieties. And for the immediate management, blood gas, because the baby may need ventilation. Okay, mandatory ventilation, IMV. So you have to do blood gas first for the management purpose. Again, for the management purpose, you need glucose, you need electrolyte, but they are after the blood gas. And also the saturation, ECG lead. Okay, this will take 1 minute to place. Okay. So these are the preliminary investigation and echo to see the structural anatomy. Now, supraventricular tachycardia management, how we will manage? This is almost similar. Okay, almost similar to the pediatric and neonate. There is no difference. You see, if shock is present, management is another kind. But if shock is absent, then what will be the management? See, the shock present. So DC cardioversion, 1 joule per kg, similar in the pediatric. And if not improved, 2 joule per kg. So when the baby is hemodynamically unstable, there is shock, tachycardia, tachypnea, gallop rhythm, and enlarged endal liver, then you will do DC cardioversion. Okay, and the dose is similar to pediatric and adult. While you are approaching DC cardioversion, do not forget to give vagal maneuver, obtain IV access, trial of adenosine. These three, okay, when you are trying to DC shock, also you have to do this thing. Vagal maneuver need only 30 seconds. In neonate, we don't give carotid sinus message. We don't give carotid artery message. Okay, who can tell me in neonate how we give vagal maneuver? Anyone?
Ma'am, cold water in immersion.
Cold water, yeah.
So you will directly pour cold water, or there is something easy method you can directly give to the child?
Cold water in blocks we put in their face.
Blocks or tissues like
like a gloves, like a plastic bag, wrap up with cold water. Okay, you will not directly immerse cold water in the baby's face. So cold water bag, there is a hot water bag, there is cold water bag. Okay, ice pack. You will put ice pack on the baby's face, not on the supraorbital or in the orbital, on the whole face. This is called which reflex? What is the name? We read in the SOP book. What is the name of this reflex that will reduce the heart rate by cold water?
Ma'am,
You
driving reflex.
very excellent.
Diving reflex.
Excellent. Or diving reflex. Yeah. What is the action of this diving reflex? It actually suppress the sympathetic stimulation and it will decrease the heart rate. This is called diving reflex. It is a protective phenomena. So when you are giving DC shock, you are preparing. That time you can pour some ice water bag into the baby's mouth. Okay, not in the nose, on the cheek or in the forehead like this. And then the baby's heart rate will gradually fall down. But the definitive management is DC cardioversion, direct cardioversion. Remember, definitive management is not IV adenosine or vagal maneuver. But vagal maneuver, if the question comes, what is the immediate action? Immediate action is vagal maneuver. Because preparation for DC shock, preparation for the adenosine takes time. At least 1 to 2 minutes, it will take time. But vagal massage, no need of any time. Okay? And suppose the baby still not improved, baby is still on shock, but you have to start amiodarone. Okay, but if the baby after direct cardioversion, SVT stopped, heart rate became normalized, you will discharge the baby? No. Every neonate that is presented with SVT, you have to refer them to the cardiologist for evaluation of the congenital heart disease. Okay, and if the baby is hemodynamically stable, I mean there is no shock, then first is always vagal maneuver, IV access, then adenosine. Okay, and adenosine's dose, sometimes they will ask you in exam question, 200, then you can increase to 500 microgram per kg. So for a 3 kg baby, you can give 1500 microgram. So the first dose is 200, second dose is very much high, 500. Okay, you can give safely in neonate. So this question I think came in exam. What is the dose of adenosine? Because adenosine, adrenaline, these drugs are vital, life-saving drug. That's why sometimes this question comes in exam. Okay, so how many times you can give adenosine? This is another question. Adenosine you can give, first dose is 100 microgram, or you can use also 200 microgram. Both are correct. Adenosine 100 to 200 microgram. Okay, so then wait for 2 minutes. If SVT do not terminate, you can increase dose up to 200, then again 2 minutes. If not terminated, then 300. By this, you can go, lastly, you can go up to 500 microgram per kg. So that means 5 times you can give. First is 100, then 200, then 300, 400, 500. So 5 times you can give. If by this time is not terminated, definitely you have to refer the child to the cardiology center or the regional cardiac center, discuss with the pediatric cardiologist, because it is resistant SVT. Okay, so discuss the further management with cardiologist. If hemodynamically stable and still in SVT at 6 hours, consider transfer. So you can manage maximum 6 hours this child. If not terminated, you have to refer with the ICU ambulance. There are 2 kinds of ambulance. One is with the ICU support, another is with the normal, for the normal child. So this baby will need ICU support, remember, ICU support ambulance. Okay, any question from this supraventricular tachycardia?
Do you want to put your dogs off? Here. Yeah, we don't know. Here. Which one is it?
Oh, you have to like turn on and then,
Okay.
there we go.
Okay. So let us start now. So supraventricular tachycardia, additional information, adenosine. You see the adenosine. Now there is some protocol for giving adenosine. Like adenosine should be given with flush within 30 seconds. Why is that? Who can tell me why adenosine we have to give in rapid flush? Why not slowly?
Ma'am, because adenosine having short half-life.
Yes, it will metabolize into the circulation. If you give slowly, it will be metabolized and it will not go to the heart. And if it does not touch the heart, okay, they cannot actually reduce the sympathetic activity. That's why you have to make sure that the dose is going to the heart. That means you have to give normal saline flush. After this 30 second, I mean quickly you are giving adenosine, then 5 cc normal saline or 2 cc normal saline flush so that the full dose goes into the heart. Okay, what is the mechanism of action and what is the side effect? We read in our pharma class detailed about adrenaline, adenosine, if you remember. So it acts on the slowing of the conduction time through the AV node. Which one has action on the SA node? Which drug has action on the SA node? We read in our pharma class. Quickly, yes? Yes, you are right. Which one?
Digoxin.
Digoxin, yes, digoxin. That
Digoxin.
node, yes. You have to very fast on this question because this question are time-saving question. Okay, which drug acts on the SN node, which drug acts on the AV node? These are your time-saving question. It will save your time. You have to answer very fast, okay? Next is intraosseous, actually we do not give. So intraosseous, there are some drugs that should not be given intraosseously, like this one, adenosine. Because if you give into the bone marrow, how many times it will come in heart? So it is ineffective actually. Okay. So never test a cannula. I mean, we do now, when we do the cannula, then we aspirate some blood for testing. Never do this. Because if you aspirate the blood before adenosine given, okay, the blood will be clotted onto the cannula. And when you are giving adenosine, it will be breakdown. It will break down. Okay, so do not aspirate the blood before giving. It's a fresh cannula. You can give normal saline flush before giving adenosine, and after giving adenosine, you can give normal saline flush. Okay, and always manage this baby in the ICU. Never give adenosine into the neonatal general ward. Give into the ICU and keep defibrillator ready because anytime the child may go into syncopal attack. So keep defibrillator ready, keep your ECG ready, okay, and check the ECG rhythm. You know, you will see this is the rhythm. Suppose this is the rhythm of SVT. What is the rhythm of SVT? Like this. SVT rhythm, there will be no P wave, right? There will be no P wave like this. This is SVT rhythm. This is SVT rhythm. And you'll see suddenly the heart will stop. And then there is P wave, QRS, and T. And then P, QRS, and T, like this. So suddenly, when you give the flash, this period, the heart will go into syncopal attack. This ECG, I think, came in AKP. Okay, the baby had SVT, and then suddenly it will stop, and then there'll be rhythm, normal rhythm. Because in SVT, there is no P wave, absent P wave. All we see that is T wave and QRS complex because of the very fast heart rate. P wave is merged. That's why we cannot see the P wave. Okay, so this is the typical X-ray ECG picture. You will get in question, you will Mrcpch, and also you will see if you manage this baby, you will see this will happen. Any question until now? So wrap a towel, immerse entire head in ice cold water for 5 seconds. Actually, we don't do immerse whole head. We actually wrap a towel or ice bag into the baby's head for 5 seconds. Okay, and unilateral carotid massage not recommended. Remember, we don't do carotid massage. We do in the children, but not in the not in the neonate. And DC cardia version, as we said, 1 joule per kg. Start from the 1 joule per kg, then you will increase 2 joule per kg. And prophylactic medication, this is important. What prophylactic medication we will give? Okay, when SVT has terminated, it is vital to commence medication so that it does not happen further. In older child, we usually give amiodarone or propranolol like this. But here, we should refer to the cardiologist. Okay, we will not treat this one, so no need to remember. Follow up. Every child with SVT should be follow up in the cardiologist with the Holter. Sometime you will do Holter. What is Holter? 24-hour ECG. ECG will be in the place and the baby will eat and sleep. This is Holter, okay? Any question? We finished this chapter. What is our next chapter? 314. Which one is next? What is the name of the chapter? Who can remind us?
Resuscitation.
Resuscitation. Very, very important chapters. Yeah. Neonatal resuscitation. Neonatal resuscitation will be in your exam, and also if you are giving any interview or anywhere in UK or in Australia or in any country, okay, if you are going some course or giving some interview, okay, it will be very, very important. Neonatal resuscitation. So let us start. My voice is clear to you? Maximum people, please respond, because someone is messaging in the group. Clear, na? Okay. So neonatal resuscitation, what you should know. Okay, this guideline is taken from the Mrcpch UK. Okay, this is the UK guideline, resuscitation.org.uk. There's a whole, all over the UK, this guideline is followed. So before resuscitating, suppose you are called, you are a registrar or a fellow, you are on call, and they gave you this number, and ensure delivery room is warm, windows are closed, fans are switched off, and the temperature is 26 degree for babies less than 28 week. Okay, so remember, any baby who is delivering and you are on call, you have to make sure that the delivery room is warm. Okay, and if the baby is less than 28 week, then the delivery room should be more warm. Okay, and cord clamping ideal time is 1 minute or 1 to 3 minutes, but better after 1 minute. Okay, within 3 minutes, after 1 minute. Why so? No milking necessary. No need of any milking. Just after birth, wait for 1 minute, then cut the cord. By this 1 minute, what you will do? You will dry and stimulate the baby by back massage. You will stimulate the baby, dry the baby, and back massage. And then after 1 minute, you will cut the cord. Okay, this is the protocol. But if the baby is floppy, cyanosed, not cried, okay, weak cry, immediately cut the cord and take the baby to the resuscitation area. In every delivery room, there should be a resuscitation area in every delivery room. Okay, so remember, when any baby has, we are called, we have to be sure that the baby's resuscitation area is equipped, well equipped. That means proper lighting, proper temperature maintaining, proper proper instruments, that is Eti Tube, Ambu bagging, oxygen, also laryngoscope, everything is ready, and one assistant should be ready. You cannot do everything alone. Okay, then there is an important line. Any baby who is more than 32, you should remove the wet clothes and cover with the warm and dry towels or clothes, anything. But this question came in exam, mark it star mark. If the baby is less than 32 weeks, do not dry body. This question is very, very important. Do not dry the baby. Just put the baby into the plastic bag from the feet up to the neck and tuck the side into the neck so that the full body goes into the plastic bag. Okay, dry only the head and put the head out and start your resuscitation. Clear? So this plastic bag, what is the need of this plastic bag? It will prevent excessive evaporation of the baby's fluid, because less than 32 weeks, we know the skin became keratinized in 20 weeks. We read from our task cases book, right? Skin keratinization started in 20 weeks, but skin is still permeable in 32 weeks or low. So the baby is more than 32 weeks, they do not need actually this plastic bag, but babies who are below 32 weeks, they need plastic bag so that excessive evaporation of the water does not make the baby dehydrated. Clear? Now your aim is to maintain the temperature 36 to 37.5 unless decision to take therapeutic hypothermia. This is very important line. If the baby has perineal asphyxia, okay, perineal asphyxia has a criteria, Toby criteria, write it down, Toby criteria. Toby criteria is important for therapeutic hypothermia. But unless the baby fulfill the criteria, you cannot just refer every child for therapeutic hypothermia. And another is, we do not usually do hypothermia less than 34 week. There is a borderline. This baby below 32 week. Okay, we usually do not do therapeutic hypothermia. We do term babies. Term baby has good prognosis, usually, okay? So this below 32 week, if you want to do the hypothermia management, you have to refer to the consultant. He will take the decision. Okay. Preterm baby may require additional intervention. Okay. So preterm baby, we sometimes put the baby in incubator or in warmer, or there are some other guidelines. Okay. This is hypothermia management, another guideline. So this is how you have basic knowledge is that therapeutic hypothermia we do not do in every baby. Another point is that if you want to start therapeutic hypothermia, the decision is after some time. So before that decision, you have to maintain the temperature between 36 to 37. Okay, so you have to maintain the temperature. This is first management. Now, there can be two kind of situation. One situation, baby is very active, red, pink, crying, okay, moving the hands and feet. This is one scenario. Another scenario, baby's color, tone, breathing, and heart rate. So we know appearance, A for Apgar, appearance, this is color, tone, P for pulse, this is heart rate, G for grimace, we are not checking grimace, A for activity, that is tone, okay, R for respiration. So this four criteria is taken from the Apgar. A for appearance, blue color, P for pulse, heart rate, R for respiratory rate, A for activity, this is muscle tone. So these are the four criteria, Apgar criteria. We will check in every baby. If the baby is floppy, heart rate is below 60, very low means what? Very low means below 60. Assist breathing immediately. So this guideline differ from the APLS guideline and American guideline, because in America now they are starting cardiac massage first. They're not giving breathing first. Okay, but here we will give chest move breathing first. So remember, in neonatal resuscitation, it differ from the adult resuscitation, also differ from the American resuscitation. So you have to follow this one, British for Mrcpch. So breathing immediately, that is by Ambu breathing, Ambu bag, or mouth to mouth. If you don't have Ambu, mouth to mouth. Okay, so reassess heart rate after 5 inflation breath. Remember, the term is called inflation breath. There is two kind of breath, ventilation breath and inflation breath. This is inflation breath. If you are giving mouth to mouth, same 5 mouth to mouth breathing. Okay, this is inflation breath. Inflation breath are more strong because you have to open the collapsed lung. More strong breathing. This is called inflation breath. And you have to give pause in between the breath, like 1, 2, like this. Inflation breath, okay? So reassess heart rate, breathing, color, tone, chest movement after every 30 seconds throughout the resuscitation process. So when you are giving inflation breath, within 30 seconds, you give 5 inflation breath, and then you will assess the baby. Is the chest is moving? I mean, the breathing started. And also, you'll check the heart rate. Okay, so if you need help, of course, you will request help immediately. If baby is not breathing by 90 seconds, so this whole process will take 90 seconds. Assist breathing, continue. So the baby, you gave 5 inflation breath, the baby did not improve. Now you will give continuous breathing. How many minutes? 60 per minute, right? Continuous breathing. Check airway. Now, after giving 5 inflation breath, baby did not improve. You have to check the airway. Airway must be open. Suppose there may be some blood clot or some meconium into the airway. So you have to check airway after 30 seconds. So this same management goes into the meconium aspiration syndrome. In meconium aspiration syndrome, if the baby is floppy, you have to start immediately breathing 5 inflation breath. Then if you can see any material like clot of blood or meconium, thick meconium, you have to remove those meconium by the wide bore suction. Now Eti Tube suction is, we do not recommend Eti Tube suction. Clear? So this is the management of, same management is for every neonate. If the neonate is floppy, please start breathing. Within 30 seconds, you have to start breathing. Okay? Now keep the baby neutral position in a well ventilated area, when a well equipped area, lightening area, hot area. The area should be warm, temperature should be 36 to 37. And floppy baby, chin up, jaw thrust, chin up, neutral position. And then you will put T-piece and soft round face mask. T-shaped soft round face mask covering the nose and mouth. Okay. Give 5 inflation breath. This is the by Ambu breathing. Okay, 5 inflation breath. The pressure, each breathing should be 2 to 3 seconds last, each breathing, and the pressure should be 5 centimeter water. Okay, start oxygen in 30%. Do not start oxygen from the beginning 100%. Start 30%, then increase. And if the baby is term baby, start with air. So from the beginning of resuscitation, no need of starting 100% oxygen. Okay, you will start with the air, ambu bagging. Then if you need, saturation is low, you have to add the oxygen. Okay, so this is the inflation pressure, 30 centimeter of water, and preterm baby 20 to 25 centimeter of water. Now still there is no movement. You have to think that maybe my technique is some mistake. Maybe I am using wrong technique, or the baby has position problem. Okay, so you have to think about the obstruction. You can do a laryngoscope and suck with a wide bore device into the neck, into the that is called esophagus. Okay, consider placing oropharyngeal guidal airway under the direct vision. So this oropharyngeal airway we can use in neonate. Remember this line. Okay, oropharyngeal airway. Have you seen this oropharyngeal airway? I think you saw this comma shape. There is a comma shaped airway, right? This is the oropharyngeal airway. It keeps the mouth open. It keeps the airway open in case of when the child is floppy. Any question until now? Resuscitation?
Ma'am, these,
yeah.
Should we learn these guidelines exactly like it is? I mean, we should be, memorize all these values and each and every point of it.
No, values are not so important, but values, some values like heart rate after 60, you will not give chest compression. Before 60, you have to give chest compression. This is important information, yes. Right? Like this. Yes. Not every value is important, but the second and the intervention you are giving, at how many seconds you are giving chest compression, at how many seconds you are giving ambu, this is important. And this is the starting topic of neonate resuscitation. This is the very starting point, A, B, C. This is A. Okay, so you have to read these full 6 pages. Very, very important. Okay. So what will be the, yes? Any question?
বুঝলেন যে ওই যে আমাদের যখন রিসাসিটেশন করে ফেল মানে রেসপন্স করবে না তখন আমরা ব্রিদিংটা কন্টিনিউ করব 60
Yes.
ব্রিথ পার মিনিট না কম
60 breaths per minute, but you have to
60
check, recheck. Yes, you have to recheck. Your position is okay or not.
ওকে
Your technique is okay or not. Baby is in neutral position or not. Why the baby is not breathing? You have to recheck again and again. And if the heart rate is below 60, you have to start both chest compression and airway, both. I'm coming to that topic, okay? Now that we know that when the baby is not starting breathing after 5 inflation breath, you have to recheck. Okay. Now endotracheal intubation, most baby are apneic at birth, they will respond with bag and mask. Remember, 90% baby will respond with bag and mask. Only 10% baby, they will require intubation. They will not respond. Okay. So nasal CPAP rather than routine intubation may be used for initial support if the baby has spontaneous breathing. If any baby has no spontaneous breathing, do not put the baby on nasal CPAP, because CPAP needs self-respiration. Clear? This baby who has no self-respiration, you cannot put the baby on CPAP. You have to put the baby on ventilation, mandatory ventilation. So severe birth asphyxia, you have to secure the airway if the baby has prolonged apnea. So what are the indication of Eti Tube? Please read. What are the indication of Eti Tube? Okay, severe birth asphyxia when there is prolonged apnea, no breathing, and blocked airway or trachea by meconium aspiration, the baby cannot breathe. You have to put the Eti Tube. You have to give external airway pressure for baby. If you want to give surfactant, if you have congenital diaphragmatic hernia. Now, who can tell me any baby who has congenital diaphragmatic hernia, suppose you see that there is shrunken abdomen, hyperinflated chest, okay, you will give bag and mask or you will put Eti Tube directly?
put Eti Tube.
Ma'am,
Put Eti Tube directly.
What will happen if you give bag and mask?
Burst.
When bowel loop will be dilated, that will push
Yeah.
pressure more on
More pressure on the injured lung, because the lung is already injured, lung is already compromised. So if you give more pressure to that injured lung, that will cause a lot of problem. Okay. So in congenital diaphragmatic hernia, we put Eti Tube if the baby is floppy. Otherwise, if the baby is pink, taking respiration, no need. But if the baby is floppy, put Eti Tube first directly. Sometimes congenital diaphragmatic hernia diagnosed in the before birth by ultrasound. So in that time, we are also sure that this baby is having congenital diaphragmatic hernia. We cannot give bag and mask, contraindicated. Remember, bag and mask is always contraindicated in congenital diaphragmatic hernia. Remember, if you fail to give a bag and mask within 30 seconds, you should revert to the bag and mask ventilation, because Eti Tube you should put within 30 seconds. That means you need skill, more skill. If you fail within 30 seconds, you should give bag and mask again. Otherwise, the baby will be cyanosed. Okay. So if the baby, you are first of all, you are giving 5 inflation breath with air, using air. Do not use oxygen first. Okay. Then suppose the baby did not revert, you are continuing the bag and mask, and you see within 90 seconds, you see heart rate is not good enough. What do you mean by good enough? Below 60. So you are measuring every 30 seconds, and at the end of the 90 seconds, you see heart rate is below 60. Because you are continuing the Ambu, with the help of the Ambu, heart rate should rapidly rise if the baby is okay. But if the baby is not okay, below 60, bradycardia, you start chest compression. Okay. Another is before starting, if the baby do not move into ventilation breathing, there are two kinds of breathing. I told you, one is inflation breath, another is ventilation breath. Ventilation breath is 3:1. 3 breath, 1 chest compression, 3 chest compression, 1 breathing. This is ventilation breath. But inflation breath continue unless heart rate is good, or you see there is chest movement. So if the baby's heart rate is more than 60, and then there is chest movement, you can see visible chest movement, you go into the ventilation breath. Slow breath. Ventilation breath is slow, less pressure, but inflation breath is far more pressure. Okay, so do not move on to ventilation breath unless there is a heart rate, good response of the heart rate. Heart rate good response means more than 60. Clear until now? So remember, when you are doing the breathing, you have to check the heart rate. If heart rate is below 60, then start chest compression at the same time. So you need 2 hands. One will be given chest compression, another will be given breathing. Review after each cycle. Review after each 30 second. Review. Okay. Heart rate is rising, that means good. Chest movement is occurring, that means good. Okay. So if no spontaneous breathing, provided the heart rate has increased and chest movement has obtained, perform 30 seconds of ventilation breath. Now, heart rate is increased. Now you will do ventilation breath. Ventilation breath, what is the rate of the ventilation breath? 30 breath per minute, 1 second. And reassess every 30 seconds. So ventilation breath is 30. It is minimum. Okay, 30 breath. Normal respiration is 60 per minute, but in ventilation breath, we will do 30 per minute. Okay, continue ventilation breath until baby is breathing effectively. If heart rate is very slow and chest movement seen, confirm chest movement within. So if you see that heart rate is still slow, 30 below 60 minutes, and you see the chest movement is going on, then you have to do cardiac compression. Okay, what is the rate of cardiac compression? Cardiac compression is 3 compression into 1 breath, 3:1. You have to remember this is the universal for only neonate, not in pediatric age group. If it is an infant, the rate will be how much? 30:2 or 15:2. Which one is now universal? 30:2 or 15:2 for pediatric?
15:2.
15:2. Yeah, previously it was 30:2. Now it is changed. Even if you are single rescuer, suppose previously it was single rescuer 30:2, double rescuer 15:2. Now they are saying universal 15:2 for pediatric. 15 is chest compression and 2 breathing. And for neonate it is 3:1. 3 chest compression, 1 breathing. Clear? So this is the neonatal resuscitation protocol. And this is the shape. You will hold the baby and your thumb should be on the xiphisternum, not in the left side, in the xiphoid process, remember, xiphisternal junction. Now, figure 2 is the resuscitation technique. You can do any technique. This is the UK guideline. Ideal hold is figure 1 and figure 2. This is the figure 1 and this is the figure 2. Both are ideal actually. You can hold the baby fully like this. Both are ideal. Alternative hold. Alternative hold means compress lower sternum with finger, not encircling the back. This is alternative position, but it is actually not good. Okay. Action. Compress chest quickly and firmly to reduce the anterior-posterior diameter of the chest by about 1/3. So this is the diameter. Okay, your chest should be like this, and you should put pressure on this 1/3, and then you should release the thumb for recoil, so that fully re-expansion. You have to give time for fully re-expansion. Okay. So this is the hold of cardiac compression, and you will give how many ventilation breath? 30. And how many chest movement? It will be 120 event. See, 120 event So every 3 chest compression, you will give 1 breath. So in 1 minute, 60 minutes will be 120 event. Among this 120, there will be how much breathing and how much respiration? Who can tell me? 90?
30 will be breathing. Yeah, ma'am.
Yes,
30
90
will
will
be
be,
breathing and 90 will be compression.
yes, 90 will be compression. So this 30 is called ventilation breath. And previously we used 60, that was inflation breath. Inflation breath are rapid and more firm. Inflation means you have to inflate the lung. And this is the ventilation, you have to maintain the lung. So there are 2 kinds of breathing, inflation breathing and ventilation breathing. Ventilation breathing is slower and pressure is less than the inflation breathing. Okay, clear? So 120 event, remember this line, 120 event. Now resuscitation drugs. What are the drugs we use for resuscitation? Always ask about mother's drug. Very important line. Before giving any drug to the neonate, always ask the mother's drug, because the mother may be getting pethidine, IV morphine for pain. So you have to ask the mother, because you need to know why the baby is floppy. Okay. Then after starting the resuscitation, effective lung inflation, you give chest compression, and by this time you perform the umbilicus venous catheter for urgent blood. You can urgently collect the blood. Intraosseous, if you fail umbilical catheter, then you can give intraosseous, but intraosseous is not good for every child. Sodium chloride flush you can give. Continue resuscitation 3:1. And then adrenaline. So remember, whenever you are giving drug, you should not stop the resuscitation. There will be third person who will resuscitate, who will manage this drug, who will put the cannula, umbilical cannula, and he will give the drug. So this drug is 1 in 10,000 solution. In our country, adrenaline is found in 1 in 1,000 solution. So how you make this 1 in 10,000? We take 1 ml from drug, 1 ml of drug, adrenaline, and 9 ml of normal saline. So it will become 10 ml total, and 10 ml contain 10,000 like this. Okay, we mixture this adrenaline with 9 ml normal saline, and we dilute it is by 1 in 10,000, because in the market it is 1 in 1,000. So every dose is 0.3 ml per kg. Suppose the baby is 3, so it will be 0.9 ml from that solution, from this dilution. Okay, and administer IV IO. Okay, dose you can increase 0.5 to 1 ml per kg. You can increase. Now, sodium bicarb limited action. So 1 to 2 millimole you can give with IV line. Never give via Eti tube. Very important line. When there is severe metabolic acidosis not responding to fluid therapy. Suppose you already given normal saline. The baby is acidotic. You will give 20 ml per kg normal saline bolus. Still the baby is not improving. You are giving 2 boluses. The baby still is in shock. And you did umbilical catheter ABG. You see there is severe metabolic acidosis. That time you have to give sodium bicarb 1 to 2 millimole. But this will be given by the consultant, not as a registrar. Check the glucose. If the glucose is less, hypo, okay, you have to give 2.5 ml per kg bolus, and sodium chloride bolus initially. Okay, 10 ml per kg. Actually, for shock management, it is 20 ml per kg. Okay, every child, shock management. So blood transfusion, if the baby is severely pain, there is feto-maternal hemorrhage, or baby has rhesus immunization. Okay, and we don't know what is the mother's blood group, what is the baby's blood group. We are just suspecting. That time we will give O negative blood transfusion. This blood transfusion will help to prevent the feto-maternal hemorrhage, hypovolemia, also rhesus isoimmunization. O negative blood is called neutral blood. They do not have any antigen in the RBC. They do not have antigen in the serum. Naloxone only given if the mother has been given pethidine, okay, and the baby, you are giving bag and mask ventilation, failed, Eti tube established, everything established. At that time, you can give naloxone. So remember, naloxone we do not give at the beginning. We give after Eti tube established. This is the guideline we have to read, that if the mother is using morphine, what is the protocol? Okay. See, this dose is not important. For naloxone dose, it will not come in exam. So read that will come in exam, not that unimportant. Do not pressurize your brain. Any question? Okay, so after, so when to stop resuscitation? This is ethical question. When to stop resuscitation? Suppose any baby who is not responding to you, to your resuscitation, you have to call the consultant or senior colleague. So 2% will decide, consider resuscitation. So despite resuscitation, consider stopping as outcome is poor. Decision should be individualized and involve senior advice. So remember, without asking senior advice, okay, if you are a registrar, you should ask your consultant. If you are a junior doctor, you should ask your registrar that should I stop the resuscitation? Because it is individualized. Every neonate is different. Every case is different. The question can come that this is the only baby of the parents and the baby was in vitro fertilization, okay, test tube baby, and the parents want more resuscitation. What will you do? Okay, answer will be like that. You will ask your senior advice, senior colleague advice, or your consultant advice, and you will counsel the parents. There is no hope situation. This is called no hope. This is ethical. I gave you the ethical note, right? No hope. This baby who has no life after 10 minutes of resuscitation, the Apgar score is 0. This is called no hope situation. In that case, if we continue resuscitation, the baby will not improve. And also, even if the baby is improved, the brain is already dead. So the baby will have severe handicapped condition. Okay, so you have to counsel the parents. You have to take senior colleague advice. And after resuscitation, definitely you have to monitor the baby oxygen saturation. Suppose the baby's heart rate improved, respiration improved, everything improved, then you have to monitor the saturation. Okay. See, after 10 minutes, the preductal, meaning right hand saturation should be more than 90. This is for normal baby. Preductal means what? Right hand, right? So you have to monitor heart rate, pulse oximetry, ECG if available, see the lead, see the rhythm. If resuscitation prolonged or failure of heart rate to respond, then you can increase oxygen concentration. So we started oxygen from air, then 30%, then you can increase. If SpO2 is more than 95, after 10 minutes, reduce oxygen. Why oxygen is so dangerous? Who can tell me? Why we are so much bothered about the oxygen?
Toxicity.
Yeah, which kind of toxicity it will develop?
Renal damage.
Retinopathy of prematurity, remember?
ROPS.
ROPS. So the oxygen is toxic for the premature eye, even for the premature brain. Yes. Okay, oxygen is very toxic. Clear? So reduce oxygen if the saturation is more than 95. Now meconium delivery. Give it star mark. What is the importance of meconium delivery? Do not attempt to suction blindly when the head is on the perineum. Before, suppose 10 years back, 15 years back, when the head delivered, they started suctioning because the fluid is meconium colored. This is called before birth suction, but now it is stopped. Now the baby fully delivered, cut the cord, dry the baby is floppy, start Ambu breathing. But before starting Ambu breathing, inspect the area This line is very important. Inspect the area under direct vision. That doesn't mean laryngoscope. Direct vision means torch. You'll see the baby by torch, not by laryngoscope. And suction by wide bore sucker, not by the Eti Tube suction, by the wide bore sucker within 1 minute. Only intubate if you suspect there is tracheal obstruction. Routine intubation is not necessary. These lines are very important. So if the baby is floppy, you will see direct vision that there is some particular particulate. If you see some particulate, give suction. If you don't see, don't give. Then start Ambu breathing, 5 inflation breath. But if the chest is not rising, you can suspect there is some material into the trachea, there is obstruction. You can intubate the child. Clear? So routine intubation we will not do. Routine suctioning we will not give. And head on the perineum, we will not give any suction. This 3 point is changed from past guideline to the new guideline. Clear? Now resuscitation, preterm baby, you will give nasal CPAP. This is very good for all. And pressure should be 5 centimeter. Okay. If the baby respiratory effort is poor, baby cannot breathe in the CPAP, intubate and ventilate. Do not delay. CPAP is not the ultimate treatment. Ultimate treatment is ventilation. CPAP is the, supportive. If the baby is premature, it will support the lung. But if the baby is exhausted, going into respiratory failure, and you did ABG and you see carbon dioxide retention, high carbon dioxide, you will intubate and ventilate. Okay, so make everything documented, record everything, timing and counseling, everything. Communicate with the parents and with the consultant. And this is your resuscitation protocol as we already discussed. Okay, see this one. Any question from this resuscitation? It's a very, very important topic. It will be helpful for your everyday life. And also, if you want to work in UK, in exam, it will come. So assess after floppiness, dry baby, after floppiness, tone, breathing, after checking, open airway, give 5 inflation breath and reassess heart rate every 30 seconds. If chest is not improving, recheck your technique, recheck baby's position. Okay, repeat inflation breath. So inflation breath, you can repeat again. Until the chest rise, you cannot continue ventilation breath. You have to make sure that the air is going to the lung. So until your chest movement is happening, you cannot start ventilation breath. You have to give again and again inflation breath. And you have to think that there is some obstruction. So you have to put the Eti Tube. Okay. So if the heart rate is less than 60 after breathing, you have to start chest compression. 3 chest compression and 1 breathing. So there will be 60 chest compression and 30 breathing in 1 minute. And see, this is within 60 seconds, this minute, within 60 seconds, your inflation breath should be complete. 5 inflation breaths should be complete within 1 minute. This is called golden minute. Within 1 minute, your bag and mask ventilation should be complete. And after 1 minute, you have to start chest compression. If the baby's heart rate is below 60, okay? And by this time, you have to maintain, hold the time, you have to maintain temperature. How much? Who can tell me? What is the maintaining temperature for a neonate? We just read.
36.5 to 37.5.
Yeah, 36.5 to 37.5. Very good. And in oxygen increase or decrease? If the baby is not taking breathing, you will increase the oxygen or you will decrease the oxygen?
Decrease.
If baby is still floppy, not breathing, you will increase or decrease?
Decrease.
Increase.
Increase. Yes. You started with air. After 1 minute, you have to increase. Because within 10 minutes, it should be more than 90 saturation. So you have to increase. And call your senior. At any point, if you feel you are not getting, you have to call your seniors. Any question? We finished the neonatal resuscitation. And now I'll stop the YouTube and